Act has come about. And I especially want to put on record congratulations to Dr. Sumati Ghosh and our own team. Now, we have with us a lot of past chairpersons of Foxy who have worked for the Foxy. And Dr. Basab Mukherjee and Dr. Bipin Pandit, our able vice presidents, are also working very hard to see that we take across this message. And I'm very happy to share with you all that Foxy and WHO India is launched the Respectful Abortion Care Project. It's going to take off soon, where we are going to take this new amendment of MTP Act to all our members, 262 societies with 38,000 members, so that every member of Foxy knows what are the changes and what is it that they need to offer when a woman reaches out to them. So thank you, Dr. Kalpana, and all the partners for coming forward and organizing this webinar. We really appreciate it, and Foxy is always ready to partner for any of these very important webinars. Thank you.
Thank you, Dr. Shantakumari, the President Foxy. Again, on behalf of Foxy, we thank Dr. Kalpana Apte, Secretary General, CEO, FPI India, who has devoted more than a quarter of a century of her life in public health. And she is a great friend of Foxy, and we have associated her and engaged with her in several projects over the years. As Dr. Shantakumari has said, the MTP committee of Foxy has been a vibrant committee over the last 15 years, and we have contributed in advocacy in different aspects of safe abortion care, comprehensive abortion care over the last 15 years. Dr. Bharti Maheshwari is here. She was one of the past chairs of the immediate past chair of the MTP committee, and there are other chairs of the MTP committee who have contributed immensely in Foxy's role in providing safe abortion services all over the country. So now we're going to move forward. We're going to hear from Dr. Dilip Walke. Dr. Dilip is a past president of the Pune Obs-Gyne Society and was a previous chair of the Medical Legal and Ethical Committee of Foxy. He is a medical legal expert, a person who we always fall back on when there are medical legal problems. Today, he's going to guide us and talk to us about the challenges that we expect to face as clinicians with the new amendments which have been made in the MTP Act, Amendment Act 2021. After this, we will be having a panel discussion, and we'll be taking the learnings from him forward and the thoughts and ideas which he shares, and we'll be discussing that with our experts. We have Dr. Bipin Pandit, Vice President of Foxy this year, Dr. Bharti, I have already mentioned, and Dr. Parikshit Tank, who is the Treasurer of Foxy this year. We will be engaging them in a discussion. So let's hear from Dr. Dilip Walke on the new act and the challenges that the clinicians face.
Thank you very much.
Can I think that was a very important point. And when the MTP Act amendment was being done, the government had called for members from Foxy, and Dr. Jaideep Tank, who was the Secretary General then, and he was the previous MTP committee chairperson, very actively took part to see that we from Foxy side put forth our views on this matter.
Also, we have some position statements, sorry to interrupt, position statements brought up by Foxy even years before, where we had asked for extension of the 20-week limit and several provisions which have now been accepted in the Act. It was an advocacy of also along with Foxy, along with several other stakeholders, which has culminated in this action by the Government of India and the Ministry. Dr. Dilip, sorry for interrupting. It's all to you now.
Yeah.
Thank you.
Yeah, Basab, I agree that it was all because of the efforts of the previous chairpersons of MTP committee and Foxy in general, because of which we have got this amendment. I mean, all this amended act is all because of the efforts from the Foxyans. Shall I share my slides now? Is it seen? Is my slide seen?
Not yet. It's just coming up. Yes, it's come. It's come, Dr. Dilip. It's come. We can see it.
Okay. So this is how, this is the title I've decided, Challenges to the Clinicians in the MTP Act and the Rules of 2021. Why is it that this is not going forward? Just a moment. I'll stop sharing and start sharing again. Has it come now?
To do screen share. So we can see your slide. Yeah, now screen share is on.
Yeah. First of all, let me thank Foxy and FPA for this opportunity given to me to talk here today. My agenda for my presentation is we'll have a look at the MTP Amended Act, which came on the 25th of March, and the rules which have just come this month. We'll reiterate what is clear about those amendments. We'll discuss the challenges. I will make few suggestions for advocacy during my presentation, and we'll take it forward during the panel discussion, and I promise to keep it short and to the point. So if we were to try want to understand the amendment, this one slide suffices. See, nothing has changed when it comes to MTP up to 12 weeks. But between 12 and 20 weeks, we know that instead of advice of 2 RMPs, now we need advice of 1 RMP only. Between 20 and 24, which was not allowed, now it's going to be allowed, wherein 2 RMPs are going to give opinion on some categories. More than 24 weeks was not allowed. Now it will be allowed only for substantial fetal anomalies, where the opinion is going to be given by the board. Infringement of privacy, this is something new that has come. Initially, infringement of privacy and confidentiality attracted only 1,000 rupees of fine. Now it is fine plus an imprisonment of 1 year. And the new thing that has come up is that the contraceptive failure indication was initially there only for married women. Now it is for unmarried women too, and that is available only up to 20 weeks of gestation. Let me start off by trying to understand the clarity, the challenges, and the suggestions that I want to give when it comes to MTP with medicine. Now, the new rules have made it clear that it can be done up to 9 weeks. All these days, we were saying, as medical legal experts, we were saying that it is allowed only up to 7 weeks. Now, after the rules, we know that it is allowed up to 9 weeks also. And we also know that MBBS with training can prescribe these medicines, provided he has got he has done 10 MTP with medicine under supervision of a registered medical practitioner in a registered center, or he has done a 3 months post in an OBGYN hospital. So these are the two things we know. There are certain challenges and confusion when it comes to MTP with medicine. Point number 1 is there is no mechanism for submitting the report. Say the Form C, Form 1, Form 2, and Form 3. This mechanism is still not clear. So what happens is the appropriate authority do not accept anything that comes from the unrecognized clinic. The attached registered center do not cooperate with these people who are doing MTP with medicine in a small clinic. So what I suggested, there has to be a separate category for reporting MTP with medicines from this unrecognized clinics. Second point is the prescription is very essential when it comes to doing an MTP with medicine. Now, will it be seen as a breach of confidentiality? And now the problem is the breach of confidentiality is going to attract 1 year of imprisonment. So if I write a prescription for MTP with medicine, will it amount to breaching the confidentiality? So my suggestion is there has to be some protection mechanism for the RMP who is doing this in good faith. Thirdly, the Form 1 is to be filled within 3 hours of MTP, which is just not possible when it comes to an MTP with medicine because the patient may abort at home. Hence, it is not practical. And the fourth point is the column 11 of the admission register talks about date of discharge. Now, when it comes to MTP with medicine, there is no admission and no discharge. So my suggestion is instead of admission register, let's call it an MTP register and let's make the column 11 an optional column. Then let's go to the MTP up to 20 weeks. And there's a lot of clarity which has happened because of the amendment. Let's reiterate the clarity. Number 1, now we know that opinion of only 1 RMP is enough for a 20-week MTP up to 20 weeks. We know that approval criteria have remained the same, whether it is 0 to 12 weeks or 12 to 20 weeks. And now they have extended the category B. It has to be read as 24 weeks. So whatever has been given to us as an infrastructure criteria up to 20 weeks now is taken up to 24 weeks. Also, similarly, the RMP eligibility also remains the same. And those who are registered for second trimester MTP center will now get automatically registered up to 24 weeks because the old act has not been repealed. It is only the new things that have been added. So every time, wherever 20 weeks is mentioned, we have to read it as 24 weeks. and everything falls in line. Indication, of course, is the same as the rules of 2003, except that the failure of contraception now, we know that is available for unmarried girls too. When it comes to MTP between 20 and 24 weeks, let's have a look at the clarities and the challenges. Between 20 and 24 weeks, we now know that opinion of 2 RMPs are needed. And we now know after the rules have come that we have to fill a new form, which is called as Form E, which has been now introduced for the sake of opinion. And we also know that there are categories or indications that have been defined. But when we go through these categories and indications, there are certain indications which need a little clarity. I mean, there is no nothing to discuss about survivor of sexual assault or rape or incest or minor. But when it comes to this point of change of marital status during ongoing pregnancy, in which they want to talk about widowhood and divorce, my question is, what about the divorce in progress? The patient may come to you for MTP while she has applied for divorce, and the divorce might take a long time. What about those divorces which are in progress? Then it comes, the fourth point is women with major physical disability as per the criteria laid down under the Right of Person with Disability Act, which means now we will have to know everything in detail about the 2016 Act. Mentally ill women, including mental retardation, is okay. But when it comes to this point of fetal malformation that has substantial risk and blah, 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 my question is, what if one fetus is normal and the other one, if it is a twin pregnancy wherein one is normal and the other one is not, then what? So it has to mention that in clear words also. Then the next point, when women with pregnancy in humanitarian setting. Now this humanitarian setting needs some explanation. This probably was introduced because of the COVID pandemic situation, and that is the disaster or the emergency that they are foreseeing. So maybe a little clarity on this will be needed. Single mothers have been excluded from this list of indications. That is what we all need to know. Now comes the most challenging part of MTP beyond 24 weeks. And there are many challenges here. First, let's have a look at the clarity. The clarity is that now there will be a medical board which will be formed by the state government or the union territory, which will either allow or deny permission within 3 days. And the 2 RMPs have to perform the MTP within 5 days. And the requirement facility for centers doing MTPs beyond 24 weeks mentions that it should have procedure under facility for procedure under sonography guidance. Hence, they will have to be essentially done in centers who have got sonography machine and who's got a PCPNDT license. Now, I don't see any reason why an MTP on a patient who's more than 24 weeks, we always need this sonography for doing any kind of a procedure under sonography guidance. Probably they are wanting to talk about doing with a needle, injecting KCL or things like that. Challenges for MTP beyond 24 weeks, the challenges can be actually divided into 2. Challenges with the board and practical day-to-day challenges. The challenges with the board, challenge number 1 is, on the board, you will see that there is only one single gynecologist that is there, and the others are a pediatrician, a radiologist, and somebody else who can be appointed. Now, my problem is, this is the only person who is a registered medical practitioner under the Act. Others who are not RMPs will decide about the safety of the procedure. So a non-gynae will now give an opinion about whether this procedure is safe or not in that particular hospital who's applied for it. So my suggestion is that only the gynae or the gynaes, you can have 2 or 3 gynaes who should be allowed to and ultimately deny or allow the MTP of more than 24 weeks, and the others should help the gynae to take decision as per their specialty knowledge with respect to the anomaly in question. So they should not be the ones who are taking decisions. This is what I feel, because otherwise it will be in hands of somebody who actually was never an RMP under the Act. Challenge number 2 is there are no guidelines to the board about what is substantial fetal anomaly. And this can lead to a bureaucratic high-handedness, because what I will apply as substantial fetal anomaly, they might say it is not. And then there is always a possibility of a problem and a possibility that the patient might suffer. So my suggestion is, there should be a proper list of all the possible substantial malformations that can be subjected to termination of pregnancy beyond 24 weeks. And this exercise actually was done following the Nikita Mehta case, and all that the government will have to do is see to it that that list is included in the rules that they have framed. Challenge number 3 is the rules mention that the board has to decide within 3 days, but there is no clarity about 3 days of application or 3 days of the meeting of the board. So the clinicians will not be too sure that if I apply today for termination of a pregnancy beyond 24 weeks, he is not too sure when the board is going to meet, and he is not too sure when exactly he will be able to offer the termination to the patient. So that clarity has to be there, not 3 days from the board meeting, but XYZ days from the time the application comes to the board. So the suggestion is frame rules about the timeline from the day of application, because after 24 weeks, earlier the MTP is done, safer it is going to be for the patient. Challenge number 3, it appears that the doctors on the board will be nominated from those already in the government service. So the challenge here is, how will they find time from the existing jobs to attend these board meetings? Because they may not get time to meet every 15 days. And if that is going to happen, then they will meet, say, 15 days or 1 month every monthly. And then the opinion is going to come 3 days after the meeting. And that will delay the process of MTP of somebody who's more than 24 weeks. Now, practical challenges when it comes to MTP beyond 24 weeks. Challenge number 1 is supposing the fetus takes birth as a live baby, and the patient refuses to accept this malformed live baby. Once born, this becomes a legal entity with fundamental right to life. So how do we solve this legal and ethical dilemma is not yet, it has not yet been made clear to us. So the suggestion is, there should be, of course, no live birth after an MTP. So guidelines about the method of termination is now essential, with details of how to terminate the life of the fetus while it is in the womb. This is what is very necessary. So this we need to have in the guidelines itself, so that we will see to it that after the MTP, the fetus that comes out will not come out as a live birth baby. Now, challenge number 2 is, if the fetus comes out as a dead fetus. Now, this is what we wish for when we are doing a termination of pregnancy beyond 24 weeks. We wish that the fetus comes out as a dead fetus. But the problem here is, if it is more than 24 weeks and more than 500 grams, then the biomedical waste provider will refuse to take it away. Then what will happen is, we will have to report it under the birth and death register as a stillbirth. Now, when we report it as a stillbirth, will it not increase the stillbirth rate in our country and reflect badly about the maternal health parameters of our country? So that again is going to be a problem, because suddenly there is going to be a rise of stillbirths in our country that are going to be reported. So the suggestion is, create separate category of products following MTP even beyond 24 weeks for biomedical waste management. So this needs to be done. Otherwise, the stillbirth rate of our country will unnecessarily be seen to have increased. Now, confusion about definition of medical termination of pregnancy. The Act merely says that MTP means termination of pregnancy by a procedure using medical or surgical method. It does not talk about the intent of termination, and the intent of termination is to terminate the life of the fetus. Now, what happens, because it is not talking about the intent of termination, will an induction of labor or an LSCS that we do before the labor pain start, will it be termed as MTP also? Will DNE or suction evacuation done for missed abortion or IUFD induction, etc., will it come under the ambit of MTP? Now, when it came to DNC, DNE or suction evacuation of missed abortion, that problem has been solved, because there was an RTI which was sent, and that has clarified that this doesn't come under MTP. But the other point is, it does not talk about whether it should terminate the pregnant state. And that's the reason why my suggestions are, number 1, it should mention the intent. You can have words like a termination by surgical or medical method that leads to or causes or hastens the stoppage of fetal heart. You have to also add this line causing discontinuation of pregnant state, because then a fetal reduction will never be considered to be an MTP, because here after fetal reduction, the pregnant state of that of the person continues, of the mother continues. So that may be added in the definition, and you should exclude treatment of medical conditions from the definition, so that all your DNE, suction evacuation, your induction of labor, your elective LSAS, that will automatically get excluded. And once and for all, this confusion about definition of medical termination of pregnancy will be solved. Some practical difficulties and challenges. Practical difficulty number one. Now, all the gynecologists sitting here will agree that the flow of a patient in a hospital or nursing home is such that maintaining the privacy and confidentiality is only easily said than done, because the patient is going to come to the reception, the patient is going to go to the accounts department, the patient is going to come to the ward, the OT, somewhere or the other the name of the patient gets leaked. And to maintain the privacy and confidentiality, one can just say that we will do it, but it is very difficult to do it. So something has to be done. The registered medical practitioner needs protection for this breach, because the breach of confidentiality now is not about just 1,000 rupees, it is about 1 year of imprisonment. Practical difficulty number two. Now, while performing surgical MTP under anesthesia, some relative or accompanying person is needed outside the OT to take the responsibility in case of emergency. And we take his signature or her signature as a witness for the procedure. Now, just because that person is witness, we may, it is very difficult to hide. Why am I taking this signature for? This signature is being taken for some surgery. Now, what is that surgery? I will have to tell. And suppose the patient wants total privacy, it is going to be very difficult to hide the reason for signing as a witness from the person who is waiting outside. So some kind of a protection of the registered medical practitioner doing, especially those MTPs under anesthesia where they need somebody to sit outside the OT, that has to be needed. That is needed also. Practical difficulty number three is Form C. Now, Form C is not as per the Supreme Court guideline of the Prabha Manchinda case, because it gives no knowledge in form of information of MTP. So my suggestion is a redrafting of the Form C is needed in such a way that information of MTP is also given along with the Form C, where you just take the signature. And in the Form C, there are words like daughter of or wife of. Now, this may reveal the identity of the patient. So my suggestion is to scrap that daughter of and wife of from the consent form. The next question is, who is this person authorized by law? Because now the Contravention of Privacy and Confidentiality Act attracts 1 year of imprisonment with or without fine. And it can also be, they say that it can be disclosed. The name of the patient can be disclosed to only person authorized by law. Now the challenge here is, who is this person authorized by law? Any government officer will come and say that he is a person authorized by law. An IT inspector, a biomedical waste inspector, any person can just come to your hospital, the PCPNDT official, anybody can come and say that he is the person authorized by law. So clarity is needed for us to know who's this person authorized by law, and protection should be offered to the registered medical practitioner if the person authorized by law comes in and that person is responsible for the breach of privacy and confidentiality. So I always say challenges are never ending. You have to have a perspective in everything when you're experiencing challenges in life. So looking forward to the panel discussion to understand the issue in a proper perspective. Thank you very much for patient listening. And I think Basab will take the discussion from here, and we will get all the answers later. Thank you very much.
Thank you, Dr. Dilip. Thank you for your wonderful thoughts, perspectives, and bringing up a lot of issues to the light. Just before you started, I think most of us thought that the MTP Amendment 2021 solved a lot of issues. And now you've opened a great Pandora's box that it's created more. possibly, and those are something which I'm sure we'll have our panel. So you've raised a lot of questions, a lot of thoughts, and a lot of discussion material. So I'll just ask my panelists to first give their inputs on what they think. Bipin, I'll start with you. Dr. Bipin Pandit is the present Vice President of FOGSI. You have heard Dr. Dilip Walke bringing up several issues which he thinks, which we know, and practically which will be issues which will be of content, some now, some in the years to come. What are your thoughts? How do you think we should be packaging our messaging to our FOGSians? What clarity should we bring in, and what are the issues of the different things which he has raised would we bring forward and try to address when we are talking about this with our members? Bipin.
Thank you, Basab, and thank you, FOGSI and FPI, for giving me this opportunity to be in this very important discussion. Now, MTP has been always a subject of controversy all the time. Everybody wanted to discuss, all the doctor community, all the FOGSians, all the NGOs, all the government authorities, and so on and so forth. It is so sad that for such an important amendment, it took so many years. And after 50 years of passing the MTP Act, we are seeing the light of the day. The only good thing is there are still many countries and states all over USA and all developed countries where still MTP is not done. So we are a developing country now. We are very progressive, and we respect the respectful termination of pregnancy for the woman and women's right. And we really have done very well. So congratulations to all those who have fought for this, including Basab, you. Now, Dilip Walke has really thrown a very good light on all the challenges. And there are so many loopholes. They were there before, they are there now, and they will be there afterwards also. Now, how do we tackle all these things? One by one, if you take, yes, there are problems, but I think representation, active representation by FOGSI to the authorities will solve this problem. And we need to take this forward, all of us together, to change, make some changes and give some clarity to our members about these challenges, what Dr. Dilip Walke has given us.
Yeah. So just let's say one by one, I think we'll bring up some of the discussions which
yes.
Because let's say about the medical board, because just first tell me about and the raising stillbirth rate issue which he mentioned. How many abortions post 24 weeks are we really looking at on an overall perspective? Would it be substantial enough to really increase the stillbirth rate, which he thought, or would that not be an issue? Parikshit, I can see you. Dr. Bharti, I can see you. Please be free to budge in. Dr. Parikshit, we had a wonderful talk by Dr. Dilip Walke. I'm not sure how much you could catch on that, but it was really eye-opening on the different issues which he brought forward.
Yes, some very important aspects, regarding the difficulties were brought in by Dr. Walke as usual, very pertinent to practical aspects of delivering the goods, on the part of the gynecologist.
So one thing is like the very important, one of the reasons why the amendment is so that we don't get delayed, because I remember Dr. Jaideep Tank in his talks also shows a very classical case where the abortion never took place and it just went on till 31, 32 weeks. And so we've had these anecdotal cases where law hasn't exactly delivered. And one of the reasons why this amendment is there to make sure that so you have the time limits, you have the things, but even in the time limits, like you say, that it's not a time limit from the meeting vis-a-vis a time meeting from the time the permission goes. So there are loopholes which legal people can ring around, and we must make sure as clinical practitioners that we are in that ambit so that the woman gets the final prerogative and her right prevails. Dr. Bharti, we want you to come in. You've heard the discussion by Dr. Dilip. What are your initial thoughts? How do you think we all know that MTP Amendment 2021 is going to make a difference, and we expect women to have to FOGSI to reach out to all women along with the other stakeholders, and we expect our women to benefit from all the changes that have happened. There are a lot of discussion which has happened. Your thoughts, Dr. Bharti, and then we'll come back to other panelists.
Yeah, good evening, everyone, and thank you, Foxy, for this opportunity. And first of all, congratulations to all of us that finally MTP Act amendment came in existence, and fortunately, it is in my tenure. So, I have seen the efforts of all Foxians and senior Foxians, how they have done, and finally it came. Now, as Dr. Walke's very beautiful presentation and has kept many issues, and as you have raised the issue of stillbirth and after 24 weeks, so here this is very important to take a clear message that though amendment has been done after 24 weeks or till 24 weeks, but we have to understand that we have to do MTP as early as possible whenever it is required. We would not have to think that amendment is done and we can do. There are certain indications when we have to do only after 24 weeks. And if issue, of course, as Dr. Wake has said, that this policy has to be made in near future, and that what this MTP product has to be called after 24 weeks, how it has to be taken care. But of course, not still birth, because if it is done, then of course the data would be different, and it has to be. I think these challenges and these issues will be tackled in near future. Yes, Dr.
Like he was suggesting of a new heading. Now that's something which again we haven't have a new heading, but again depending on the numbers, possibly that may be something which we'll be looking into the future. One other point which was very importantly brought up, I want to bring Parikshit in here, was a substantial fetal anomaly, and substantial defined by whom. And that's I think that's what he was bringing up, and which is so important, because we know fetal anomalies. You have to bring the fetal medicine specialist in, and then he spoke about the medical board having just one gynecologist, other people who have little knowledge about fetal medicine, and now how do they interpret, how do they take a call? But Parikshit, your thoughts on how you think that this part of the act, whether it will be a hindrance or whether it will be a help? And then I'll come to Dr. Bipin with the same question about substantial fetal anomaly. How much does, what role do we play as a gynecologist, and how can we convince the medical board if there are people who are not so well aware with the subject?
Yeah, I think, Basab, this is, really a question which can rack anyone's brains. And what's important to understand is when we talk about fetal anomalies, we are not only talking about things which are going to be lethal. We are also going to talk about things which are substantially going to affect the quality of life and the amount of hardship that this newborn is going to face. Not only the child, but also the entire family, I believe, because, a lot of healthcare in our country is still private driven. So those kind of considerations have to be taken into view when we put something into the group of substantiative or substantial fetal anomalies. Now, as gynecologists, I believe our role is to have as much latitude as possible for the couple. So, for example, say a complex heart disease may not be a total no-no for a given couple who is young, spontaneously conceived, etc., etc. And they may opt that, okay, this is going to be too much for us to handle. But for an older woman who's been waiting for a child for her entire life, this may be her only chance. So I think, our job is to facilitate that decision rather than make encumbrances to it. So our role, and I'm sure Dr. Pandit will bear me out on this in the board, as and when we get opportunities to represent our colleagues and our fraternity, is going to be to bring latitude to this definition of fetal anomalies.
So latitude to the couple, latitude to definition of fetal anomalies. I think that's something which will definitely be discussed. It was already discussed before, but now it will discuss all the more because you crossed the limit and you're going right up to the top. Yes, Bipin, Dr. Bipin, Pandit, your thoughts.
My take on anomalies are any anomaly or malformation is a financial, emotional, and a social burden on the couple. Now, there's a very thin line between what is severe anomaly, what is the anomaly which threatens the life of the fetus, and what are the other anomalies. Now, where do you take the decision to terminate the pregnancy? which are the listed anomalies? It's going to be a very difficult question. And as Dr. Dilip Walke rightly said, we need to have a clear idea about the anomaly and the listed anomalies, that these are the listed anomalies where they definitely need termination of pregnancy to save the couple from financial, emotional, and social burden. Number one. Number two, there will be certain anomalies where there can be discussion in the board, medical board, whether this needs MTP or this doesn't need MTP. Now, the couple might find it that, yes, I don't want this child with this anomaly. But the medical board might say, it has happened before, that the pediatric surgeons have said that, yes, this anomaly can be treated by surgery, so we cannot terminate. Now, there can be 2-3 different opinions about a particular anomaly, given anomaly, but for that couple, any anomaly of any sort, whether it's life-threatening or not life-threatening, is going to give a lot of burden. Now, who has to decide this? It's going to be a very difficult question. We need to have enlisted malformations, anomalies, which will definitely need termination, and there are certain anomalies which need a little debate. Now, answering your other question about stillbirth rate, see, there was no social awareness about this after Nikita Mehta case and after the media. So society came to know that, yes, this is possible. So there were many anomalies and heart conditions in the baby which needed termination, but patients were not coming forward. Slowly, many patients started coming forward. The medical community also was not aware that this is possible. Slowly, they got aware. Then the cases were referred to medical board. As Dr. Dilip Walke said, there was a delay in taking decision. Some people cross a lot of time as far as gestation. But all this need to be streamlined. There has to be a particular meeting dates more frequently, and the decision has to be taken within 3 days as per the guidelines to terminate a pregnancy. There has to be enlisted malformations and anomalies which definitely need termination, and certain which need little debate. Who has to decide all this? The parents might be wanting it, but doctors might say, no, this doesn't need termination. It's going to be a very difficult question.
Yeah. So like putting it practically, the parents, obviously they had asked for termination. That's why it's gone to the medical board. Now the medical board would say, no, you don't need to terminate, and then that becomes a problem for the parents. Dr. Bharti, do you think
one more thing, Basap?
Yeah.
Here again, when the case is referred to the medical board,
what about
the question of privacy? This stringent punishment about the privacy of the patient has to be removed. Initially, it was 1,000 rupees. Now, no fault of doctors, the privacy can be breached. When you refer a case to a board, she is exposed to many people, her name and identity.
That's another point which will come in. Dr. Bharti, do you think Foxy can play a part in enlisting the number of the congenital anomalies or the serious or substantial fetal anomalies, and suggest to the government that these are some things where we could consider termination or put it to the medical board? Parikshit, is it possible? Can we do it? Can we even try it? Because there are some things which we can do. Dr. Bharti, would you suggest your successor, Dr. Richa, possibly to look into these things where we can contribute? Because we understand, again, as Dr. Dilip said, there is something which has already been listed from a previous case. So if there's something which Foxy can look into and possibly give the list of these are the fetal anomalies we think are almost incompatible with life or severely detrimenting quality of life, as Dr. Parikshit said, then we can possibly put in a word and give them something which is useful. Dr. Bharti, how can we play a part in all this?
Yes, Dr. Basab, Foxy is the association which definitely play a role, and it has to do, and we have to do a very fast effort to enlist anomalies where the termination is mandatory and where it is optional. It's like this list, and with the help of neonatologists and pediatricians and other forum, definitely Foxy should suggest this list as early as possible, and then it would be helpful for the government, and they will also can have with their officials meeting, and definitely the work in this direction would be hastened. I think so.
One exercise which we can do, we can try. I think we can try with in association with the NNF and the Pediatric Surgeons Society of India, possibly there's something which we can contribute in some ways. The next point, Dr. Bipin, you brought in was confidentiality. Dr. Bharti, I'll come back to you. So it's been clearly mentioned by Dr. Dilip, it's so difficult, a patient getting admitted to a nursing home for an MTP. So you say XYZ out there, but that XYZ doesn't translate to the final word. There's some XYZ keeps on changing. So XYZ, it may be written on the admission registrar by somebody, but then you need the Aadhaar card, you need the admission thing, then you need somebody in the accounts, as you rightly mentioned, then somebody will be talking behind the back. So it's a so big a challenge of privacy. How big a challenge of privacy do you think is things now in your clinical practice, in your experience? Dr. Bharti, we'll hear from you, then we'll go back to Dr. Bipin on this point.
Actually, Dr. Basab, it really seems practically a little bit impossible, or how to maintain every RMP that we have to maintain the confidentiality. And because as Dr. Walke very clearly put all the points that if you are writing on the prescription, if you are mentioning the name on the consent form, you are mentioning the name in the admission register. So it is definitely RMP should be free from this rule. I think confidential, there is no other option, what I feel. And Foxy should also send their recommendation, or should do effort to put this point for the government of India to find out this problem. Otherwise, for clinicians, they will avoid to do MTP, what I feel that it is really a difficult problem.
Yeah, anyways, second trimester MTPs are challenges in Maharashtra. Generally, we have heard about this for different reasons, the misoprostol dispensing to everything. Parikshit, I'll just bring you in another point, I think, which we were mentioning about the live baby delivery. And for that, like as Dr. Walke was suggesting, there are different things which we can do, which we do is a sonographic guidance for injection of KCL into the fetal heart. Now, is that going to be a regular feature, or would you take mifepristone to do the trick, or mifepristone often doesn't do the trick in our clinical practice? It's not always the way it works. Can I hear from you, Parikshit? Then we'll hear from you.
Yeah, so Basab, I think this is one of the questions which Dr. Varsha Jambagi has asked, and I answered it on the chat, that should terminations of pregnancy beyond 24 weeks only be managed in centers where there are facilities for invasive procedures? So again, the invasive procedure would not only be diagnostic, but it would be a termination of pregnancy by injection of KCL. I think this is the most humane way going forward, because I don't think we can rely on any of the agents to do the job very securely. And you'll have a baby who will come out with a little bit of cardiac activity, some muscle tone, some gasping breathing movements, and that could lead to very complex ethical problems going forward, because this couple has decided that, well, we don't really want any part to do with this pregnancy, and they've probably made up their minds that this is not going to happen, this is not going to be a live child. But when the child is born and there are signs of life, how does the clinician approach this? I mean, if we just leave things be, then that would itself be quite inhuman. So I think going forward, this should probably be the way to approach the situation, that yes, KCL injections beyond 24 weeks should be mandated.
Dr. Bipin, let's come to you. Dr. Bipin, this is not the first time that we've had deal with these situations. We deal it in extreme prematurity. There are times when you have live babies delivered at 24 weeks, 25 weeks, 26 weeks with PPR or with otherwise. If it was not for a fetal anomaly, it was not for a termination, how would you generally be dealing with it? This is how we've done it all the time. So would you like to say how different is this from anything else?
See, when it's not at 20 weeks, initially, when this amendment and act was not passed, anybody would try to save this baby, however it is. And in certain centers in Mumbai and big cities, Kolkata and Delhi, it was possible to save the babies of 24 weeks also, 26 weeks also, of extreme prematurity. The other practical situation and problem which all of us have faced, and you will agree with me, that I'm not talking about medical abortion, but whenever bigger pregnancies, so many people in the hospital and nursing home staff is involved who is non-medical. When something like this happens, people become very sentimental around you. It becomes very difficult to do anything. So this also we need to consider. So there has to be some definite method which we need to devise or do something by which this thing is taken care of. And then there is no emotional drama after this.
Yep.
Even the patient who is involved should not change your mind or should not do something. And I feel there has to be a separate category, not as a stillbirth, coming to your original question, as Dr. Dilip Phalke said. Something needs to be discussed and debated and brainstormed about this. It's going to be very difficult.
Yeah, again, easy said, difficult to do, more questions, less answers. Dr. Bharti, will come to you. In this perspective of the new amendment, is there any difference in the training, in the skills which our clinicians need to have or adopt in the new, in this, or is it easy? 18-week termination and a 24-week termination, would it be the same? How would you think that, is there any skill development which clinicians would need to have to handle late abortions better? Number one. And like about the manuals with the GOI, Government of India, and some of us have those manuals, do they need to be changed in the light of the recent amendments?
Dr. Vasab, in the Amendment Act, in fact, the eligibility criteria is same. And as we all know that already in the eligibility criteria, trained gynecologists, they can do the MTP. So we all postgraduates or perfectly trained, only they can do MTP after 12 weeks. So of course, those who are eligible for doing the 24 weeks or above MTP, they all are the gynecologists. But of course, when we are doing the MTP for 20 to 24 weeks, we are still doing 20 to 24 weeks, that many cases we are doing, and we are doing, the Foxias are doing lots of training programs, and we are improving the skills of Foxians, and they themselves are taking training, and they are inviting the experts for doing the all webinars and training I have seen in last 3 years. But now when the above 24 weeks in certain condition is also allowed, then definitely with our experiences, whatever challenges will be comes in the clinical scenarios, and what should be the ideal methods, how we have to handle the complications and all, definitely we will go for the as a Foxies, the webinars, our training programs. Definitely skills should always be improved, I think so. So definitely there will be a certain new challenges when we will abort after 24 weeks, or more cases 20 to 24.
Like the scarred uterus and the use of misoprostol is
Yes.
one very thing which comes in
Yes.
mind. Like that is something which was there before, but now it will be there all the problem.
Yeah,
So
the lower segment may not be so forgiving, as the
Yeah.
pregnancy goes forward.
As it goes forward. I agree with Parikshit. Some
Sir,
parting thoughts. Yes, Bipin, I think we need to close.
Can I say something? Yeah.
Yeah, we need to get your parting thoughts because we need to close. It's just about time. We want to talk thoughts from Dr. Bipin, Dr. Bharti, Dr. Parikshit. Yeah, Bipin first. Yeah.
No, regarding this, I think we need to impart little specialized training for these late pregnancy terminations. Every gynecologist is not tuned to it. And personally, I feel that all this late pregnancy termination should be preferably done in institutions, not in small nursing home places. This is what my thinking is.
Agree. That's one point which we'll definitely look into later. More chances of complications in a better center with better equipment and better way to handle. Dr. Bharti, some thoughts and concluding remarks from your end. We want to wrap up. We'll hand it over to Dr. Aruna for her concluding remarks.
Yes, MTP Act amendment is a very useful thing for the women as well as for clinicians, both. And the clinician should get the advantage of this MTP Act amendment. And many things are clear, and many will be cleared soon. So definitely we should get, we should be skilled for later termination of pregnancy. And Dr. Vipin already has said that normally second trimester termination is already recommended in the tertiary centers or the big hospitals. So it would be done in the big hospitals or tertiary centers where skilled faculty as well as equipment both are available. Yeah.
Dr. Parikshit, your parting thoughts and concluding remarks before we wrap up.
So I think, the amendments will open up completely new vistas for discussion, for debate, and that's the way forward, really. I mean, everything is not going to be absolutely laid out on a highway. There could be some bumps going forward. There could be some potholes, but I think in general, physicians and gynecologists across the country have shown great maturity when it comes to handling evolving situations. And I'm sure that these amendments will be used in the best interests of couples and of women.
Thank you. Thank you very much. I'm sure that we are able to give a lot of insights to all our attendees here. And I'm sure that we have questions. We have raised a lot of thoughts, and with a wonderful talk for Dr. Dilip and some discussion with our experts, we have some clarity. But I think, as Dr. Bharti also mentioned, and Dr. Parikshit, we will have more clarity in days to come once we implement this and once we get back to clinical practice. Some concluding remarks from Dr. Aruna Suman before I hand it over to Dr. Kalpana back. Dr. Aruna, some vote of thanks and some concluding remarks from you.
Thank you, Dr. Basar. And I thank Dr. Kalpana Apte Madam for this opportunity. And we have discussed many things, like Dr. Deepak Walke sir said, that we can face so many challenges and problems with the new amendment laws that we got after 50 years, waiting for 50 long years. And Bipin sir really said the Foxy should take over in putting forth the challenges, like the raising of the stillbirths and the substantial congenital anomalies, how this should be tackled. And Bharati Maheshwari madam, she also said how we can take care of these challenges, what is the role of the Foxy, what Foxy is going to do in tackling such problems. And Parikshit said it is a real challenge for the family and the child who lives after this substantial fetal anomaly, how this should be taken care of. Thank you, sir, for this input. And Bharati madam also said there should be a lot of research work on this, and we have to take some protocols in actually taking what is the exact procedure in doing MTPs, the protocols to be followed uniformly all over the India to minimize the complications in advanced termination of pregnancy. Thank you so much, Basab sir, Bipin sir, Parikshit Tang sir, and Kalpana Apte madam, Bharati Maheshwari madam, for all the inputs. Thank you so much.
Thank you, Dr. Aruna. On behalf of Foxy, on behalf of everybody in Foxy, we want to thank Dr. Kalpana Apte and FPAI for leading this discussion. This is the first of many discussions which will take place, not just with the FPI series, but generally all over the country. I think we'll have a lot of thought-provoking discussion on different aspects of the Amendment Act, which we need to smoothen out, straighten out, and make sure that the women's rights are seen best in the interest of the women first, and all our clinicians need to contribute in that regard. Hand it back to Dr. Kalpana for closing the session.
Thank you, Dr. Basab. That was an amazing panel discussion, which followed the keynote address by Dr. Dilip Walke. A lot of things to do now emerging from this. But before I say anything, I'm delighted to introduce the President of FPA India, Dr. Ratnamala Desai. Dr. Ratnamala Desai is a gynecologist and obstetrician, and she is the principal of SDM Medical College in Dharwad. And this is one more connect between Foxy and FPA India, that these two organizations are so close. But for now, she is ours. And may I request you, ma'am, to say a few words about today's webinar.
Good evening, ladies and gentlemen. It was a wonderful discussion, particularly Dr. Walke's presentation as usual. But I think we have a very long way to go, because though the amendments have come, there will be so many hurdles which we have to cross, particularly when somebody was talking about the list of anomalies where we're going to terminate. Where do we draw a line? Now, when I said I'm going to terminate a Down's baby, one of the British trained gynecologists was angry with me. He said, "How do you do that?" But the situation in Britain may be different, where there's a lot of social support, whereas that is impossible in India. So fatal diseases, nobody questions, and anencephaly, nobody questions whether you should terminate or not. It is obvious that you terminate an anencephalic fetus. But whether a clubfoot fetus, whether the parent wanted to have a child with a clubfoot, whether a parent wants to have a child with kyphoscoliosis, or the famous Nikita Mehta case where the child had complete heart block, which is said to be treatable. Now the cardiologist said they would treat. So there are so many controversies, and then we have to sit and chart out and thrash out this whole topic. And still there will be some borderline cases where some people would opine that you need to terminate, and some people would opine that you wouldn't need to terminate. But it all depends upon the parents. Now, ultimately, it is a choice of the woman. So I think we'll have to leave the choice to the woman. My body, my choice. She has to decide, and it is not the doctors who have to decide. Thank you very much, but a long way to go. Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am. You have really ended it on a rights-based note. Thank you so much. And there is a lot that we need to do. And one thing which immediately has come out from Dr. Walke's presentation and this very important panel, we need together as partners, we are 13, 12 partners together, need to sit and write maybe issues which need further clarifications, and we certainly need to have a common letter to the ministry, and that is coming out very loud and clear. So here I appeal to Foxy as well as, of course, all partners who are here on this call and others who are not part of this particular webinar as hosts and as presenters. Let us together work on writing to the ministry about decoding, of course, the rules, and then to suggest a way forward, if I may say so. The webinars have been organized with a view to see that we have come so far. How do we go next 5 or 10 years, and what needs to be done? You have given us a very important way forward and an action area. So thank you, Foxy. Thank you, Dr. Basab. Thank you, everybody, Dr. Vipin Pandit, Dr. Bharti, Dr. Suman, Dr. Parikshit, and of course, Dr. Dilip. Thank you so much. A big thanks to Dr. Shanta Kumari and Dr. Basab for holding it together. Please let us not forget the next one, which will be led on the research and the data, which will be led by Population Council and International Institute for Population Studies. So Mr. Rajiv Acharya and Dr. Chandrasekhar, who have been on this call, will be leading it 1 week from today. So please do join us, and let's look at the data needs and the data gaps around abortions in India. Thank you so much. Have a very good evening ahead. Bye-bye.
Thank you. Thank you. Thank you.
Bye.